Now Swapnil sir will introduce our next speaker.
So our next speaker is Dr. Unnikrishnan AG. He is a diabetologist and endocrinologist in the Chalaram Diabetes Institute, Pune. He has done DM endocrinology and MD medicine after his MBBS. Over to you, sir.
Friends, thank you for inviting me for this meeting, and it's a pleasure to discuss case studies with the time and range. These are the learning objectives of the meeting. Number one, the need for a new measure of glycemia. Number two, understand the basic aspects of time and range and its comparison to HbA1c. And number three, the application of time and range as a clinical tool with case studies. Now, hypoglycemia is preventable by diabetes awareness and dietary measures. Newer diabetes medications have substantially reduced hypoglycemia. And of course, the era of continuous glucose monitoring has also contributed to understanding and management of hypoglycemia. Now, if you see this patient, whom I saw many years back, this patient is on a premix insulin. What you can see is that on day one, with the same dose of insulin, she is having hypoglycemia, whereas on the same dose of insulin, on another day, there is hyperglycemia. So HbA1c is 9%, but this does not reflect hypoglycemia. So HbA1c is intrinsically flawed because it doesn't reflect hypoglycemia. It has got a lot of interferences from several factors, etc. So that's why we need a new measure. And let's look at what is time in range. Time in range is a percentage of time that a person with diabetes spends with their blood glucose levels in a target range. This will vary from person to person, but general guidelines say starting with the time in range of 70 to 180. So just to give you an example here, here you can see the blood glucose readings, and here you can see the time in range between 70 to 180. So you will see that in the x-axis you have the blood glucose readings, and you can see all the blood glucose readings are within the normal range. This suggests that the time in range is 100% because all the blood glucose readings are within the normal range. Let's look at this patient. This patient has got some of the blood glucose levels are low, some of the blood glucose levels are high. Some of the blood glucose levels are normal. So 50% of the blood glucose levels in this patient is within the normal range. So the time in range in this person is about 50%. In this case, all the blood glucose readings are high. If you take 70 to 180 as normal, if you draw the line at 180, you will see that all the blood glucose levels are high. So the time in range is 0%, but because as you can see, all the blood glucose readings of this patient are high. So you will agree that time in range reflects hyperglycemia. It reflects hypoglycemia by giving you the time below range. And it also reflects normoglycemia by giving us the time in range. Now let's take 3 patients. All these patients have an HbA1c of 7%. All these patients have a mean blood glucose of 154 milligrams per deciliter. But in this patient, the time in range is 40%. The middle patient, all the sugars are normal. You can see all the sugars are normal, so time in range is 100%. And in this patient, majority of the blood glucose levels are normal, which means time in range is about 70%. You will agree with me that all these patients require a different management of their diabetes. There are several studies to show that the higher the time in range, the lower is the chance for diabetic complications. In this particular study, if you go from the lower quartile to the second quartile, to the third quartile, to the fourth quartile, as the time in range increases, the prevalence of mild retinopathy decreases, moderate retinopathy decreases, and vision-threatening retinopathy decreases. And all these p-values are statistically significant. So generally, as you can go from left to right, the time in range goes up. And as you can see, when the time in range goes up from 10 to say more than 70%, when the time in range is more than 70%, the frequency of retinopathy is only 5%. And where again the time in range is more than 70%, the frequency of microalbuminuria is also 3%, showing you that the more time that you spend in range, the lower is the chance of diabetic complications. So each 10% decrease in the time in range is associated with a 1.64 or 64% increase in retinopathy and a 1.4 hazard ratio, which means a 40% increase in microalbuminuria. So how do you compare time in range with HbA1c? HbA1c is the average of 3 months. Time in range gives you the data from the sensor. HbA1c is interfered by various biological factors. Time in range is mainly interfered only by treatment or lifestyle. HbA1c is correlated with complications. While time in range, there are some studies to correlate it with complications. These studies are not very robust. HbA1c does not detect hypoglycemia. Time in range reflects hypoglycemia. HbA1c does not reflect variability. Time in range, by showing you the time below range and time above range, it reflects variability. HbA1c is not easy to explain. Time in range can be understood by anybody. HbA1c, you'll have to tell the patient how, it is a hemoglobin, percentage of hemoglobin that is bound to glucose, etc., etc. Hemoglobin stays in the RBC. The time in range is very simple. You just tell the patient it is a percentage of time that the blood glucose levels are normal, and it's a very simple concept. HbA1c is a single measure. Time in range is a more complex measure. HbA1c is less expensive. Time in range is more expensive. If you look at a time in range of 70%, that means the A1c is 6.7%. So the guidelines say that time in range should be 70% or more. Less than 4% should be hypoglycemia, and hyperglycemia should be minimized. This will help reach a HbA1c target of 6.7%. Now, in very frail and elderly people at risk of hypoglycemia, you can be okay with a time in range of 50% or more. These are, of course, the time in range targets. For type 1 and type 2 diabetes, the time in range should be 70%. In pregnancy and type 1 diabetes, time in range should be 70%. Gestational diabetes and type 2 diabetes pregnancies, it should be more than 80%. In older people at high risk of hypoglycemia, time in range should be about 50%. And hypoglycemia, as you can see, should be minimized. So I've looked at why we need a new measure of glycemia, because we need to represent hypoglycemia, know the variability, etc. I also discussed with you the basic concepts of time in range. Now let's look at the application of time in range as a clinical tool with case studies. Now in this slide, this is a 72-year-old gentleman, a diabetic with chronic kidney disease, proliferative diabetic retinopathy. He has post-CABG status, is on premixed insulin. Now what you will find is that his median shows some degree of intraday variability. The central line called the median shows you how much it varies during the day. For example, you can see that the blood sugar is touching about 200 at about 11 a.m. This dark blue area shows the inter-day variability between days because of the medicine. And the light gray area shows you the inter-day variability between the days because of diet and exercise. This is the glucose monitoring indicator. It is 8.1 and the average glucose is 186. But see the time in range, it's only 40%. In this 72-year-old gentleman, we have to keep a time in range of at least 50%. So you need to minimize the variations, you minimize the hypo and hyperglycemia. Now this is a type 1 diabetes on basal bolus insulin therapy. What you will find is that all the blood glucose levels are running low. Why did this happen? Because in a type 1 diabetes patient, when you start insulin, what you will find is that the pancreas gets rest and it starts making some insulin and patient's diabetes resolves. This is also referred to as the honeymoon phase. Now, this is a type 1 diabetes honeymoon phase on insulin, and the dose of insulin needs to be reduced. Now, this is a patient who came to me with request for good glucose control, and I found that his time in range was 81%. So that was very good. But I found that there was a tendency for hypoglycemia. So when I looked at the individual readings, I found that every Monday he decreases his food intake because of some fast. He takes only fruits or very minimal food. So he has hypoglycemia on Mondays. So what I did is, though his time in range was 81%, I reduced the insulin from 666 to 3 units on the days when he fasts. And the basal insulin, I continued to give the same dose, but the bolus insulin or Lispro, I reduced. Just to show you that time in range is not enough, you have to look at the daily patterns and detect this hypoglycemia as well. Now, this is a gentleman. We know that type 1 diabetes should not be treated with premix insulin. So unfortunately, this patient was on premix insulin when he came to us. And this is a CGM from 10th July to 24th July. You will see that the time in range is only 11%. So only 11% of the time the sugars are under control. 89% the sugars are high. And the median is high. If you take 70 to 180 as normal, the median is high and all the sugars are high. So you can see this is from 10th July to 24th July. Now I'll show you 25th July to 8th August. You can see 25th July to 8th August, the time in range has quickly improved to 34%. And that's because we shifted him to basal bolus insulin. The daily average has also improved. And you can see that the time in range was 11%. It has improved to 34%. The time spent in hyperglycemia was 89%. It has come down to 64%. So just to highlight that basal bolus insulin is a treatment for type 1 diabetes. But as you will see, the glargine given at night is not lasting 24 hours and the sugar is just going up after 4 p.m. This suggests that in this type 1 diabetes, you may like to give glargine twice a day to improve the time in range. Or you might have to shift to a U300 glargine or a degludec. This is a patient whose CGM showed fluctuation while changing the pump. You can see that on 29th of October, the time above target was almost 100%. And that's to show that when a patient changes from one pump to another insulin pump, a new generation pump, there may be a period of hyperglycemia. This is to show you that time in range can also be detected with a simple glucometer. Now many glucometers have the software. This is a 54-year-old gentleman on empagliflozin, sitagliptin and metformin. Time in range is only about 10%, but you can see that his average is 147. Why? Because the time in range, instead of 70 to 180, I have values. His earlier average was 99, but majority of his sugars were low. This will also give you a graph like this, but you see the number of readings is too small. You cannot compare it with a CGM. This is an elderly gentleman on basal bolus insulin, and you will see that he's doing very well. Time in range is 75%. But if you see his record, on 2 days, his blood sugar was high. His glucose monitoring indicator is good at 6.7%. His daily average is good at 147. So this is to highlight this gentleman had eaten a bhaji, which is a high calorie food on just 2 days. And on those 2 days, it was a little high. But overall, it did not impact the time in range. This is just to highlight the clinical point that a person with diabetes can occasionally have a carbohydrate-rich snack and get away with it in terms of long-term control. But the key word is occasionally, because as we all know, little drops make an ocean, and it's important to control the blood glucose levels. So is time in range better than HbA1c? That's not the question. Both are good markers of glucose control, and HbA1c really is associated with diabetic complications. At this stage, time in range and HbA1c are useful, and they complement each other and they do not substitute each other. So I've discussed the need for a new measure of glycemia. I looked at the basic aspects of time in range in comparison to HbA1c. I also discussed some case studies in real-life practice on time in range. It has been an absolute pleasure discussing this topic with you. And my good wishes to all the delegates at SwasthyaCON. Thank you for listening to me. And thank you for the organizers and the recording crew and the entire team of the IT crew for making this a grand success. Thank you, ladies and gentlemen.
Thank you so much, Dr. Unnikrishnan, sir.